Hello, everybody. Welcome back to the Scoliosis Dialogues podcast for SRS. And today I have the honor of talking to Dr. Glotzbecker, who wrote a very interesting paper, if I recall, in May of 2025 in the Spine Deformity Journal. And the title of the paper is Cure Patients with Early Onset Idiopathic Scoliosis After Serial Casting Are at Risk of Recurrence at Intermediate Follow-Up. And today we're going to talk about all the details of this paper. So Dr. Glotzbecker, thank you so much for agreeing and taking time to talk to us. Please introduce yourself and we can, I think, take it from here.
Thank you. Michael Glotzbecker, I appreciate the opportunity for the SRS to do this podcast and recognizing this paper. Certainly want to recognize my co-authors, including as well as the Pediatric Spine Study Group, as this was originated from data from that group. So my name is Michael Glotzbecker. I'm a pediatric orthopedic surgeon in Cleveland, Ohio. I work at Rainbow Babies and Children's Hospital. I'm the division chief of pediatric orthopedics there, as well as the interim surgeon in chief for Rainbow Babies. I've been a member of the Pediatric Spine Study Group for a long time, and so this was just a paper that came out of that group.
Well, thank you so much. I forgot to introduce myself, so I'm Dr. Daniel Cunha. I'm a spine surgeon from Brazil, so apologize for the accent. If you can't understand the accent, please write to SRS and complain and get better hosts. But Dr. Glotzbecker, I think we need to start with the basics. Your team looked at 40 children with early onset idiopathic scoliosis who we called a cure. And you classify that with curves under 15 degrees after casting, and you follow them for, 2 years. I think I need to start with why did you want to study this group? Was it something in your practice that came to your attention, something that you were noticing with the recurrence or the so-called cure kids? Why did you came up with that idea?
Well, I think a lot of the research questions we get often come from parent questions or patient expectations. And I think that parents who take care of kids with early onset scoliosis, particularly those who are casted, they have a long journey ahead of them. And one of the first questions that they have is whether or not they'll be cured, right? And so we sort of know from the papers that about a third of kids with idiopathic scoliosis will be, quote unquote, cured where their curve is less than 15 degrees. And then, the expectation once you're cured is maybe you'll stay cured and remain cured forever and you won't ever need anything else. And so you have to sort of understand for the parents, as far as counseling, what does it mean as they go forward? Do we need to still see them with x-rays? Is there a chance they may need to go into a cast again? Is there a chance that they're going to need a brace? Is there a chance that they may even, go on to need surgery? And I think that the setting those expectations is important, both so that you can counsel the parents effectively, but I also think that it's important from a clinician standpoint so that you know that this is a reason that you should follow them, right? So it doesn't mean that the story is done and that you need to continue to follow them so that if you see some progression that you can then act on it.
Okay, that's pretty cool. I think we all see that on our practice. Kids that we believe that will no longer need treatments, but sometimes they get worse and we have to start the treatment all over, and you can see the parents with the disappointment on their faces.
Yeah, agreed. So I think, like lots of things that we do, I think, talking to parents and having a relationship with them, particularly kids with early onset scoliosis, that's what we do. It's a long journey. And I think the more you can be transparent, set expectations, the better it is. And then if there's a recurrence, they have much better understanding. But if they sort of think that they're cured and that they're done, which, some people assume, then when that does happen, then it leads to a lot more disappointment.
Interesting. You set a very strict definition of failure that on the paper you say that any increase greater than 6 degrees beyond 15 degrees or any need for rebracing or surgery. It's strict. I think it's within the literature. And how did that cutoff affect the design of the multicentric study? And being a multicentric, did it affect your bracing protocols? Did you have any difficult aligning all that with a multicentric study?
Um, you know, we thought a lot about what the criteria for failure would be. It's sort of difficult to define because ultimately failure is probably needing surgery. Like you could define it as broadly as that, but there's impacts for people that need to be braced. And then we sort of thought about, okay, well, what do we consider to be progression? And most people sort of believe progression to be in most scoliosis that it progresses more than 6 degrees. That's what we sort of view because that's within the measurement of error. And we said, well, that's sort of a strict criteria if a curve just increases 6 degrees. But when you're talking about a curve that's under 15, in this population, 6 degrees probably gets you close to 20. And that's when you start thinking about maybe you're going to be bracing or certainly watching them more closely. So, we had, like most of the things we do, there's not, especially in this population, there's not super clear cut definitions. There's even people who argue that cure is less than 15 or less than 10, and we had to make a decision there as well. But I think you have to start somewhere. And so we went with the general feeling of that the progression is greater than 6 degrees, because that's how we define it when we're following people clinically outside that measurement error. But we said that it also had to be bigger than 15. So if you had a curve that was 3 and went to 9, but you're still under treatment range, or where you maybe watch them more closely, we didn't think they would apply. So that's why we added that caveat that it had to be more than 15 plus the progression of the 6.
Very interesting. And the results, the numbers were eye-opening, I believe. And on the paper, you followed 40 patients, and then 10 of those patients, 25% of the children had curve recurrence. And the average time for the failure on the paper is 2.4 years. And 2 of those children eventually needed surgery. And were you surprised by the recurrence, the 25%? And do you think it's more related to the biology of the spinal growth or the brace adherence after casting?
I think the short answer is yes. I think a little bit of all that. I think that I was surprised actually how high it was and how short it was because, I've casted a number of patients that have been quote unquote cured. And early in my practice, actually, I didn't follow them that closely, admittedly. And then I had someone come back with a recurrence that ended up needing to be braced and ultimately had surgery. That was a pretty far follow-up. It didn't happen until their adolescent growth spurt. So I was surprised that it was, almost a quarter of the patients and that it was at 2.5 years. The sort of concern or the scary thing about that is that that's only at 2.5 years. And a lot of these kids, if you're starting them, they're cured, they're younger. A lot of them are going to grow much longer. So that failure rate will only go up, over time, because we by the nature of the research can't follow these kids all the way up to skeletal maturity, which would be ideally where you do. It's really hard in a multi-center database to understand the difference in treatment protocols and as well as things like brace adherence, as you sort of point out. So, people probably have slightly different brace protocols, and it's difficult. That's not that well recorded in the database. And I think even when you record it well, as we all know, there's a lot of patient variability in reported hours and what you're actually doing. And, a lot of these kids were obviously before we had true brace sensors, and maybe we're not putting them in those kids. And so I agree that there's a bit of a black box after they come out of the cast, how long they're treated and how they're treated. But we do have some data in there, but it's a little bit difficult to discern the details in sort of a multi-center database.
Okay. And I would like to bring the classical meta into the discussion, the article from she wrote in 2005 in JBJS. She followed like 94 children and treated them before they were 2. And essentially she followed them for like a decade, and only 2 of those patients relapsed. And I would like to know, like, in your opinion, why there's such a big difference between your recurrence and meta? Do you think that the patient selection, casting techniques, or our expectations changed in the last 20 years?
Yeah, it's really interesting. I mean, obviously, Dr. Mehta sort of popularized and sort of was the sort of the she had the technique down. I mean, so she had it, but the problem is if you look, our start point is after they're cured, right? And so if we got them all to that cure point, that takes out some of the casting technique or the cast design or things like that because we're actually just focusing on those that are cured. Um, you know, Maybe the protocol after they came out of the cast was a little bit different. Maybe she kept them in the cast a little bit longer. Maybe there's difference in compliance with some of the post-op protocols if they're braced for a period of time. So it's sort of tough to know because she followed them out for 10 years. You obviously in a multi-center database have patients that are treated at different centers in different ways, which could influence it. I mean, that was one site where everything was very controlled, but ultimately, if you get everybody to cure and some fail, the reality is they fail. I mean, the data doesn't lie. So it's difficult to sort of explain because it wasn't a difference in getting them to that point, but there was a difference after we got them to that cure point, which is, I think, a little bit difficult to understand what the difference is. But the reality is it happened, right? So we saw the failures and but again, not all of them went all the way to surgery or bracing, right? So our criteria for failure was maybe a bit stricter as well.
Yeah, I mean, and flipping that coin, you had like a 75% rate of success. So, I mean, that's something that to be celebrated, I think, for 30 patients that were cured, they remain cured.
No question. Again, when you talk to families, like it's important that they know about the 25% is, but the reality is, 75% of the time they are going to still be okay. But again, at the follow-up we have, some of those also are likely to, progress at some point, and particularly because a lot of them may do reasonably well in the growth years from age 4 to 10, which are relatively slow compared to very early in your adolescent growth spurt. So you probably have some concern that some of these may recur at adolescent growth spurt, but we just don't know. But I agree.
Yeah.
I think the positive thing is, 75% of these kids are not needing treatment and are cured, which is a positive.
The glass is 75% full.
Yes, absolutely.
Yeah. And also in your paper, you refer to two recent papers, I think is Federac for 2019 and Reagan for 2023. They have a similar failure rate at yours at 20-25%. Do you think this represents a more realistic follow-up from kids to puberty?
Yeah, I mean, I think, often with diagnoses that are relatively uncommon, right, where you have to get larger numbers to understand, what's happening. You sometimes need several sites, several different papers, sort of looking at different populations to see where the data sort of is going to center. But now you have this multi-center group, and you have those two other groups that sort of sit and say, yeah, about 20 to 30% are likely to relapse. I think that tells you that that risk is certainly there, and it's probably somewhere in that range. And we probably will continue to learn more over time, certainly as we accumulate more patients in these databases. But it's sort of the challenge of studying these rare diagnoses with very specific treatment patterns because it takes a lot of patients to really hone down what happens. And we're talking about kids that are less than 18 months of age or young or less than 2 or less than 3 that have so much growth ahead of them. And to perform, research where what exactly happens to a 2 or 3-year-old out to skeletal maturity and get the numbers to support that is very difficult. But, I do think that those two papers and this sort of tell us enough to say, yeah, there probably is a recurrence rate that's a little bit greater than maybe what was originally described. And, and that's probably high enough that it means that you should follow these patients as they grow. And I think, simply that's probably enough because then if you're following them, then you'll pick up recurrences earlier and maybe be able to influence treatment at a younger age. If you get a little bit of progression and you can go back and do a brace and keep it from surgery, that's a lot different than having the patient disappear for 10 years, come back with a 50-degree curve that then is, destined to have surgery. So I think those give us enough information to tell us that we probably should be following these kids to detect early recurrences, given that the rate is high enough to sort of warrant that.
Interesting. And did you change anything in your practice after the paper? Are the returns a little more often, or did you change your brace protocol or anything like that?
I have not changed my brace protocol, but I certainly have kept a closer eye on them in follow-up. So, I mean, the challenge is you can tell them to go away for a year or 2 years, but then patients get lost. So I think early on, I see them a little bit more frequently at the beginning, and then I tell them that I'm going to continue to watch them all the way to skeletal maturity. Whereas, early in my practice, admittedly, some of these kids I'd let go away for a while, and then they get lost to follow-up, and many of them probably did just fine, but I did see one patient come back, which sort of made me start thinking about this in a different way.
Interesting. And so we need future studies. If you could design the ideal prospective study to answer this question, like once and for all, what do you think that study would look like?
Um, well, I think that you would need a consistent protocol. So everyone. I think you still take a cohort of patients that are cured, and you have to decide what that's defined. But I'm fine with it being less than 15. Um, you then would need to take patients who have a consistent postoperative protocol. And if you were to not have a consistent postoperative protocol, so I should postoperative post casting, meaning a brace protocol, like you have to wear X number of hours for X length, right? And you may have two different groups of people. Some people may say, you know what, you only need to night brace for a year. Some people might say you need to do full time for a year and nighttime. So you decide what those two protocols are, and then standardize and make sure you have temperature sensors in both groups so you understand the compliance and the number of brace hour wear, sorry, the number of hours that they wear the brace. And then you follow them to maturity. Really, this is more of a natural history study in my mind of patients that are cured. So, if they all get, you could also just have it where they all get one post casting, algorithm and then follow them all the way to skeletal maturity. But I would say that if you were to design a comparative study, you'd have to find what are the differences between post casting bracing protocols and then really standardize them to make sure that you have two cohorts that are following those specific protocols.
And like I'm thinking, coming to the end, do you have like a message for like for us who have like less experience with than you from casting and treating those young kids, like a message that we could improve the quality of our care?
Well, I think the journey of taking care of kids with this disease or early onset scoliosis, it's a journey that you're on with the parents, and there's going to be ups and downs. And I tell them that there's never one straight path. And I think the most important thing is continually communicating with the parents. A lot of these parents are very well informed. They're advocates for their kiddos, and you and them both want the same thing, right? You want the best possible outcome. But it's not always easy to predict what's going to happen. And so, I think constantly communicating with them, having open dialogue, being transparent, being honest with the cure rates and what the expected cure rates are and what the failure rates are and what do you define as success and what do you define as failure are all really important things to set up with the family ahead of time.
Well, thank you so much. Thank you for taking the time and bringing clarity and honesty to this important topic. I think the message is very powerful. From what I got from it was like casting works, but it's not the end of the story. I think we need to follow those kids and really take it as it comes. Sometimes you have real success and celebrate with the families that you have the success, and sometimes you have to start all over. And having real expectations, it really helps.
Yeah, it doesn't detract from the treatment at all, right? It just helps you figure out what you should do with these kids after and how you should counsel the parents. So yeah, it's still the best thing often for these kids. And again, the glass half full, as you said, a lot of these kids are going to be cured and you win. Some of these kids you're going to keep away from surgery. That's still a win, different kind of success. So it doesn't take anything away from the treatment, but it does help us in our expectations and the patient's expectations, both need to be aligned.
Once again, thank you so much. And for everyone who wants to read the full paper, it's in the May of 2025 in the Spine Deformity. It's titled Cure Patients with Early Onset Idiopathic Scoliosis After Serial Castings Are at risk of recurrence at intermediate follow-up. Thank you so much, Dr. Michael Glotzbecker.
Thank you.